Insulation.
What was the last thing said? Fluid regulation, right?
Mm-hmm. Yeah.
And then somebody said vitamin D synthesis.
Yeah.
So we have protection, thermoregulation, fluid regulation, vitamin D synthesis. All right, so that would be the most important. So imagine burning the skin. So now you have over 30% burned area. So we call that total body surface area burned. So are these functions existing when you have a severe burn?
No.
No. Okay, so let's keep these in mind as we go through the chapter. Let's go back to your textbook. The American Burn Association changed the category or criteria for burn depth. Okay, this is the how deep is the burn. So they went from first degree to fourth degree to now the thickness. Okay, they changed the category, but really it's almost the same. Nothing much changed from the criteria. So there are four things that will determine the severity of a patient's burn. One is the depth, how many tissue layers are burnt. So that's here, the depth. And then we also have how much of the body surface area was burned. So that is now TBSA. Okay, so that is now TBSA. And then another thing is the location. Which part of your body was burned? Typical locations that will increase mortality and affect the patient's recovery are, let's say, you burnt your eyes, you burnt your, there's airway involved. Okay, typically if you have chest burns or neck burns and facial burns, fire and heat always rise, correct? So therefore, the patient during the burn process may have inhaled heat. In addition to that, if the patient was burned in, say, a closed area, so then we have smoke inhalation as well as a concern. And then finally, another factor that will increase or affect the severity is the patient's comorbidities. If the patient already has heart, kidney, lung, or other chronic problems like diabetes, then healing and compensation will be severely affected also. Graduates who have taken the NCLEX say they receive questions on burn prevention, and the questions weren't really about the med surg part of the burn. It was on prevention. So these were the possible answers on the test. One of them, which you will never expect the NCLEX to ask, is the number and location of the smoke detectors. So let's look at those. Let's see where they put this. Right here. So where should you have smoke alarms or smoke detectors?
In the living room, upstairs mostly.
Okay, so each room should have one, and then one on each level, meaning each hallway. Um, and make sure their batteries are changed every 6 months. Typically, the fire department advice is during time change when we go from every time we change clocks. I mean time, daylight saving time. That should also be the time that you check the batteries and change them if necessary. But how many of us actually do that? Honestly, I've never
Uh,
changed my. Yeah, I've been
yeah,
this.
you just remind me to do it.
Yeah, I've been in this house for 7 years now.
Most fire
I've
alarms have
changed
a
it.
beep when the battery gets low, so I feel like you don't even have to check because it tells you. It starts
Uh,
beeping over and over again.
Yeah, it's the most
yeah,
annoying beep.
So you have to
that's
change it, and it starts like well before the battery dies. So unless you don't mind chirping every 5 minutes, you're gonna get annoyed and change it.
um if that feature is on it. um some smoke detectors are too old that they don't have that, or maybe the low battery alarm is faulty. Okay, so just make it a habit that you guys really change it. It's worth it. Okay, you really don't want to, especially those who live in apartment buildings. That's a very dangerous place if you have a fire. Just watch these. Okay, I mean, read these on your own. I'm gonna read it on your own. I mean, for you. Let's go now to the causes of burns. Burns can be thermal, meaning heat, and heat in turn can be dry. Heat can also be moist. We have um, we also have contact burns, which is still hot. Let's say you're driving a motorcycle and your naked leg comes in contact with the exhaust pipe. Okay, so that's contact heat right there. And obviously, if you actually got burned, so either from gas or any other fuel, especially around the holidays when it's stressful during meal preparations, some accidents may occur, and then you ruin the holiday. Electrical burns are considered the grand masquerader. They say grand masquerader because the injury to the skin that is visible is minor compared to the organ damage that the electricity caused. So the damage to the skin, there's usually one or two sites, meaning a typically there's a contact site where you actually touch the power source, the electricity source. So of course that area will be burnt. However, if the electricity exposure was quite long, then there will be an exit wound as well. So as the after the electricity passed through your body, it will of course exit somewhere. I've seen burns in my um, second job. I think it was. I worked for a hotel. One of our electricians had because the hotel was a resort on the ocean, plenty of water everywhere. There's water in the beach, water also within the facility. But I mean, not a pool. Okay, this place had lagoons, so it's like having saltwater pools within the property, and it spanned over 7 hectares of water. So there were frequent burn accidents, but they most were minor. This I remember this one time. This electrician had almost like a stigmata. Okay, so he had burns on both palms. So one was the entry, and then the other wound was the exit. You can tell also um, from the appearance of the wound that it looks like something entered it, and then on the other palm it looked like something came out of it. So it was easy to see the entry and the exit. I mean the contact and the exit burn wound. But anyway, he had to be taken to the hospital because it's routine that if you have electrical burns, they should be checked because the again the damage is not on the skin. It's really on the organs because the electricity passed through several organs and it may have caused some cardiac issues. So they need to be worked up in the hospital. Chemical burns. Chemicals can be acid or alkaline or even organic compounds. We have different examples here. When we go to the first aid later, the important thing about chemicals is how you handle it. One thing to remember is that for as long as the chemical stays on the patient's skin, the burning process will continue. So the important thing to consider is to remove that chemical off the patient's skin. So if the chemical is also on the clothing, then of course the clothing must be removed. We'll get to the interventions shortly. Radiation burns can occur whether or not the radiation is therapeutic. We also have radiation from industrial facilities, like if you work in a power plant, for instance, or you work in a nuclear weapons facility. Okay, so everywhere you have radiation. But for the radiations we have here, since there are many radiation treatment centers for cancer and other disorders, the radiation burn we're talking about here is therapeutic radiation. Okay, so some of our patients, mostly cancer patients, may experience therapeutic radiation burns. Let's begin with burn depth. So the American Burn Association again classified them according to thickness. Superficial, this is the example. You have sunburn, for instance. Okay, so this is only going to involve the upper layers of the skin, the epidermis and part of the dermis. Then you have superficial partial, and the appearance here will be different. We have a table giving you the comparison of the appearance. Questions on the test will be identifying the burn depth. So I'll give you the appearance of the wound. So let's say I go with the burn area appears wet with weeping blisters and are pink. And then you're asked to identify what burn depth is this. And then so on with deep partial thickness. Let me go to the if this helps you remember, then go to the figure. If not, stay with this table. Table 51-1 gives you the appearance of the burn area on number 3. You could also, what will help you remember is if you compare it with this figure right here and remember what's involved, what structures are in there. So for instance, you know that blood vessels are right here in the dermis area. No, sorry, in the subcutaneous layer area, but then your hair follicles are here. So that means the epithelium layer is actually also here. And this, well, of course, the epidermis, these are all dead skin cells anyway. So that's why you don't have much damage if it's a superficial burn. And then, of course, this one is now deep full thickness, and then this is full thickness. Somebody had a question? Okay, no. So for instance, why aren't there blisters in full thickness wounds? Why doesn't blisters form?
Because you're down to the subcutaneous layer.
All right, because now for blisters to occur, you must have an intact skin above where the fluids are. So of course, in full thickness, the skin is gone, so there can't be blisters anymore. So you only have blisters if you still have skin, meaning by skin I mean the dermis and the epidermis. Okay, so those are the only burn depths that still have blisters. And with the color, why does this thing here still appear pink or red? Pink or red here, and then you when you go past the dermis, why aren't there no more um, uh, it why isn't there no more blanching?
Destruction of the blood vessels.
All right, so blood vessels, remember, are in the subcutaneous layer. So if you have destruction of that, then of course the burnt area won't have any blanching anymore. I won't ask you about necessary, but how the wound characteristics here, this definitely, because you're asked to identify what the depth of the burn is. So either use these or on the paragraph. There will also be a question about examples. So what are examples of a superficial burn? Okay, let's say for instance this one. So this is a pretty bad sunburn. Where does this fall? Or this one right here. See, you have the blisters, but they still are very pink. And this one is after they already removed they popped the blisters open, debrided the blisters. Please also, this box is also testable. I have a question on 51-4. This because this is now your first aid. However, the first aid only applies to superficial and partial thickness burns. So these are your actions. Why don't we put ice?
Because the body's lost its thermoregulation ability because of skin damage.
All right, but is that your full rationale?
It's also vasoconstriction. I think.
Right. So we need blood flow to that area. So putting ice will actually further impair blood flow to the area. Cool compresses are okay, or you may run the injured area under cool water. No blisters, then no, I mean no open blisters, then no dressings. Okay, so this is for superficial only. Okay, do not apply this to all burns. Again, this is only applying to superficial burn depths. This lotion here is the Sylvadene lotion. This is not Jergens or any other cosmetic lotion. Okay. This one for pain, and then of course fluids and rest. The deeper you go, I know we had a picture there of a debrided blister, but it has to be done surgically. Do not attempt to do it on your own. First of all, the environment wherever you're going, you're doing it is not clean, so you'll end up contaminating the wound. Wash them simply with soap and water, and then here's the antibiotic, because of course this is now partial thickness, so this is deeper. And then teach them the signs of infection, because now again the skin is definitely broken and this is deeper, so they need to be aware of possibility of infection. Now let's continue with full thickness. Please read these on your own. In full thickness, this is now beyond the dermis. So therefore, can the skin regenerate?
No, no.
It can't.
It has to be
Because look,
graft.
yeah, right. The very structures that produce the skin cells are already gone. Here, all the epidermal, dermal structures are destroyed. So therefore, can they grow? Can they grow back?
No.
No. That's why it says here, these types of burns do not heal spontaneously. You have to put now. How do we grow skin now?
Look at that.
These
Graft, you put the graft.
Okay, so these patients will now require grafts. However, on the NCLEX, since they do not test grafts because none of us are expected to work in a specialty burn area after graduation, so we are limited to first aid and prevention of infection, and then emergency management of burns during the emergent period. There will be no questions about grafts. Besides, even if you have a patient with a graph on a test question, the questions will always be about, is the graph working or not? Is the graph infected or not? So we already know, generally speaking, what are the signs of an infection. So we will still be able to answer those questions about skin grafts, because again, the question won't be about what is it, how do you apply it. The questions would rather be complications of a patient who has a skin graft, whether it's for burns or for cancer. So here is an example of a deep partial thickness burn. This one is well done. Okay, this is still very crispy. Okay, this is still good. This one though is already overcooked, so this one won't be good to eat anymore. This skin right here, this is still crispy. You know, if it reminds you of really crispy pork when you roast it, you know, dip it in vinegar and a little bit of soy sauce, really crispy. This one is very bitter already. No, that's overcooked. All right, let's calculate the TBSA. There are different rules, but for our purpose, we will only use the rule of nines. Rule of palm, it's pretty simple. They, you know, using the size of the patient's hand. But anyway, we're not using this. We're using the rule of nines. The Lund-Browder classification is the most accurate. This is the one used in specialty burn areas. It's quite difficult to memorize. So this is hours. So for our exams, we'll use the rule of nine. So everything is nine. So to total 100% though, we need the 1% on the perineum. So any involvement of the perineum, we assign 1% to that. Okay, it doesn't have to burn the entire perineum. Okay, so everything's 9. So the whole head though is 18, but we assign 9 to the anterior, another 9 to the posterior. The entire torso is 18. So 18 for the front, and then the back is another 18. The whole arm is also 18. However, each side of the arm is 9. The whole leg is 36. No, sorry. The whole leg is 18. However, it is 9 per side. Sorry, I think I said 18 for the arm. No, I mean 9. The whole arm is 9, but that's 4.5 per side. 4.5 for the anterior arm, 4.5 for the posterior arm. Then each leg is 18, but 9 per side. 9 anterior, 9 posterior. So let's try burning Who wants to get burned? Giselle, thanks for volunteering. So if Giselle is
No.
my patient, she is a quadriplegic. I give her a bath every day in a tub, and then today I just happened to grab the wrong bottle. Somebody put a jug there of hydrochloric acid to clean the bathtub and didn't take it away. So I thought it was for a bubble bath. So I laid her down, I put some water in, and then without knowing, plus she's a quadriplegic, so she cannot feel anything. So I put her flat on the in the bathtub with some water, and then this time she's laying right now she's laying on 2 inches of acid, hydrochloric acid. Calculate her TBSA. So she's laying flat on her back. For those who care, please calculate.
Is it 65%?
What did you get?
65%?
60 what?
65?
No, that's too much. Again, she's laying supine on her back on 2
56.
inches of acid. What was the second number?
56.
56. Again, that's too much.
49,
49, yeah.
Too low, but you're getting warmer.
50.
50. It's 50. 50.
Warmer.
Oh my God.
Is it 41% or 42?
Okay, so let's count. So the back of the
52.
head is 4.5, right? So the back of the head, and then her whole back is 18. And then each side of her arm, yeah, each side of her arm is 4.5, so that both arms is 9. And then
9.
the back part of her legs, so that's 9 each, so that's 18.
18.
And then don't
18.
forget, some of her tushy will also be injured here, so we assign 1% there also. Okay, so
Oh,
don't forget the tushy. So how much total is that? 5, 12, 21, 29, 33. I got 50.5 TBSA.
Okay.
Professor,
You don't
is
include the
that-
hands?
You weren't yet.
whoa.
No, we just do the entire arm. I don't know why they
Okay.
put 1% here, because if you do 1%, this will be 102 now. I don't know why they put 1%, because if you total
So,
everything, that's
Professor,
100. Okay, so this is
so it's
18.
only 9 for the hand. We don't include those 1%. Yeah, because when I was
Yeah.
adding up, it's 1 or 2.
Okay. Yeah, it shouldn't be there. I mean,
Okay.
because if you total that, that'll be 102%.
Okay.
Keep it 100. The 1% should only be assigned to the perineum. But I'm sure
Professor,
yes, go ahead.
Head
the
is-
back is also 1%. I mean, the butt is 1% as well, right? So 1% front, 1% back.
Well, I'm really referring to the perineum because it's 2 inches, so it's gonna reach. And I forgot to tell you that Giselle is 102 years old, so her labia is probably dangling down in the water, and touch the liquid. So we
Oh my
attach
God.
1% there. But I haven't seen it, but I've heard that what happened.
Oh man. Oh my.
Everybody got that? So on the first exam, you'll have a math question on TBSA. The other questions will be about fluid calculation. We'll get to that next. So we'll do severity, and then we'll go on a break. Okay. So this part, oh, wait a minute, we just started class. No, we have 15 minutes to go before break. Um, so I mentioned earlier the patient's other comorbidities. So if the patient has, let's say, heart failure, kidney failure, that will also play a role in the severity of the burn. Because of course this is a very serious injury. So will you have sympathetic and renin-angiotensin system here in play? Compensatory responses.
Yes.
Yes, you need it, right? Because this will go into, the patient will go into shock. Two types of shock again, either distributive or hypovolemic shock. So of course it will trigger your compensatory mechanism. So you'll have increased heart rate, you'll have vasoconstriction, you'll have fluid with water and sodium reabsorption from aldosterone, all of those. You'll also have antidiuretic hormone release. Okay, so these you need your vital organs for this. So you need a well-functioning kidney, well-functioning heart and lungs, and of course well-functioning adrenal glands as well. So things like patient's age, like if they have diabetes, heart disease, pulmonary disease, or renal disease, this will also make the severity worse. Or as I mentioned earlier, if it involves inhalation injury at the same time. We'll skip this is now the lung browder. Look at this. Look at that, the detail here. Okay, unless you insist, I can use the lung browder for the exam.
No, we'd rather the other one.
Oh no, no, please.
All right, so we'll do just the rule of nines. Okay, let's look at the anatomical changes and the functional changes also. So remember we looked at the functions of the skin earlier. You gave me 5 functions of the skin.
Yeah.
Okay, we'll skip the anatomical. Let's go straight to the functional changes. The reason I'm skipping this is not really necessary about zone of coagulation. That doesn't matter. It's really on the function. Okay, what happens in the um, with the vascular changes and the tissues around the area, because they go from the local, meaning where the body part that was burned actually, and then this will become systemic. The functional changes extend to the rest of the body. So let's begin. So we burned your tissues, right? So quite seriously. So let's look at now what are the effects if we burn human tissue. Let's go to the vascular changes right here. Okay. This part here are just telling you about the compensatory mechanism. For instance, respiratory. If you have inhalation injuries, of course, there will be swelling there, local swelling, and that will therefore constrict your bronchus, which makes what do these patients necessarily have to have? Once you see that they sustained a inhalation injury,
A trach.
or
Or intubation,
okay,
intubations.
intubation. So the patients will have to be intubated. We go again as we did in skills lab. When do we switch to a tracheostomy?
When it's longer than 10 to 14 days.
Okay, so if we go beyond 10 to 14 days, or according to ATI was exactly 14 days, then we go to a trach. But as long as this patient survived the first 48 hours of the burn, they actually have a good prognosis. Because the most crucial part here is during the first 24 to 48 hours of the burn. If they survive that, they have a good chance of recovery, unless they develop sepsis down the road, and then they could still die from septic shock. So we'll discuss the intubation under the gas exchange module. Okay, so we'll skip that part. Under cardiovascular, these are again all about compensation here. So the heart has to work harder because, of course, the is there vascular resistance here when there is now widespread vasodilation?
No.
No. And then also the fluid shift that are involved here, which I'll discuss right here. Let's go to the fluid and electrolytes. So the effect here is if you burn a blood vessel, no questions. If you burn it directly, of course, it's destroyed. It becomes no like black. Okay, so you burned it. It's no longer functioning. However, for the rest of the vessels that were not directly injured, will they still function normally? Hello?
No.
Okay, so as stated here, the patient will have hyperkalemia. Why? Why does the potassium level rise?
Because the cells are destroyed and they're leaking their contents.
All right, so the rationale is here. Potassium from damaged cells are released into the blood. And then as these continue, you will have potassium and sodium leaking as well. So what happens to your potassium and sodium levels in the blood? They
It
will
rises.
okay, so this is initial, okay? We're not this is not going to be the same all throughout. So initially both potassium and sodium levels will go out. And then after this period, then they will be the opposite. So initially hyperkalemia occurs. No, sorry. I stand corrected because the potassium is a intracellular cation and then sodium is an extracellular. During the initial stage from the injury, there will only be hyperkalemia and hyponatremia. Okay, sodium will be low because it's in the extravascular, and then remember the patient lost a lot of fluid here. So initially there will be hyperkalemia and hyponatremia. However, after the capillary membrane permeability increases now along with the massive vasodilation, then now both will be low. Okay, because now you're leaking fluid now. So what will happen to the viscosity of the blood here at this point? Because now all the water as well as the albumin are now leaking out of the vessels because they become leaky. So right here you have increased capillary permeability, okay, because that's the natural reaction to injury. And as stated here, there's large fluid loss because not only is water going out, but albumin. So large molecules like albumin is now leaking out because of that increased capillary permeability. So therefore, you lose protein, you lose fluid because they always go together, making your blood very viscous. And now once you have that viscosity, and because you're leaking all the fluid, look at this. How long does this thing last? 8 to 36 hours after the injury. So as that is occurring, this is how you're losing these electrolytes here. But initially, during the first few hours, you're dealing with hyperkalemia, okay, because of the direct injury to the burnt cells. And then hours later, as this now sets in, when you have this capillary permeability increase, wherein your capillary, all your blood vessels become very leaky, they now lose albumin, no proteins, and water. They go into the interstitial space now, so leaving very little left in your bloodstream. So the blood now becomes very viscous. Are you with me so far?
Yep.
Yes.
So
Yes.
now you have low blood volume. What happens to blood pressure?
It goes down.
It goes down.
What
Decreases.
happens to tissue perfusion?
There is no
It goes
tissue.
down.
Decreases.
Okay. So does this resemble, is this shock?
Yes.
Yes.
Yeah. So
Burn
this is
shock.
what we call burn shock. However, it's just um, like I said, the description earlier, because of the vessel changes, that part falls under distributive shock, correct? However, on the side wherein they're losing fluid, absolutely and relatively, it also falls under hypovolemic shock. So the evidence there is, signs of shock. You have low blood pressure, tachycardia, reduced urinary output, all manifestations of shock. So here, this is a separate category on its own, but we still just put this either on distributive shock or hypovolemic shock. However, when this period stops, so let's say granting the patient survives the first 8 to 36 hours of injury, meaning this change here, the increased capillary membrane permeability, stops because this one is not going to be forever. This condition here, this state of increased capillary membrane permeability, is temporary. This is how the body reacts to a severe injury, not just burn. So if you remember in septic shocks, for instance, was this um, indefinite in septic shock?
No, it's
No.
changed.
No.
Oh, there was a stage, right? There was just a period, a phase um, during septic shock that this occurred. It stops eventually. So right here, once it stops, this last paragraph here, all you needed to do is just keep them alive during this period here, because eventually this capillary membrane permeability increase will eventually stop. And then when that happens, fluid gradually returns into the vascular space, and then you'll have improved blood pressure, improved cardiac output, improved perfusion. Your evidence here is diuresis. So you go from decreased urine output, meaning oliguria, to now diuresis.
Okay.
If you notice also, this was evident in acute kidney injury, was it not,
Yes.
last semester? So we talked
Yes.
about the oliguric phase of acute kidney injury. So this is
Yes.
exactly the same pattern. So you go from not having urinary output, you go from oliguria because this is happening, you're losing fluid from the vascular compartment. They're leaking out, they're just coming out of the blood vessels and into the interstitial space, and then some of them are evaporating from the burnt areas where there is no skin. Eventually, when that period stops, then the fluid returns. But of course, just like in acute kidney injury, remember that means what are we doing during this initial period here? How do we keep the patient alive? Because they're constantly losing fluid.
Give them fluids.
With fluid replacement.
All right, so we're doing
Yeah.
large fluid because there's large fluid loss. We're also doing large fluid replacement. However, when this period starts, when the capillary membrane permeability increase stops, and now fluid returns or shifts back into the vascular compartment,
It's
and
perfect.
at the same time you're still running massive amounts of fluid,
No,
what will the patient have?
fluid overload.
Yeah.
Fluid overload. All right. So it's very important that you watch, because once you see diuresis, that means the fluid that was all in the interstitial space will now begin to go back into the bloodstream. So the edema will start to stop, and that is your cue that we need to change the IV fluid rate now. We don't need the massive fluid infusion anymore, because at the same time the fluid in the interstitial spaces are also entering the vascular space. All right.
Alright.
So, Professor, we just slow
Yes.
down the fluids, right? But we don't stop it. We still continue to give fluid.
Yeah, not yet. But we definitely need to lower it. You'll see what I mean when we get to the fluid rate. Are
Professor,
you?
sorry, can I
Yes.
ask? I'm a little bit confused because you said that the fluid that leaked out of the capillaries is still in the body, so it goes back into the capillaries,
It's the
No,
plasma.
no,
or
no,
not back into the capillaries, but into the vascular system.
Mm-hmm.
no. Here. So here, when we say increased capillary membrane permeability,
Right.
or also called fluid leakage,
Uh-huh.
the fluid here left the vascular compartment.
Right.
However, they went out there but didn't enter the cell. So they're somewhere
Right.
in between the cells and the
Oh.
blood vessels.
Is
That's why
that
the
third
patient,
spacing, Professor?
the same concept, yeah, the
Okay,
same
okay.
concept as third spacing.
So
So
the
it
fluid will
means,
re-enter the vascular space when it's
yeah,
in
at
third
this
space?
period now,
Okay,
because
thank you.
right, because the cause after about 48 hours, this leaking of the capillaries stop occurring. It just stops, and then therefore no more leaking. Fluid then slowly returns to the vascular compartment, increasing your blood volume
How
while
does
at
the
the same.
fluid move though? I'm a little confused by that. Like
Okay,
without the
it's
albumin, if the albumin's leaked out, it doesn't exert like the hydrostatic pressure or,
okay.
colloidal pressure and stuff. How does
Yeah,
it
I
move?
see what you mean. Remember osmosis?
I remember that.
Okay, so osmosis will cause the return of these fluids back inside.
Okay.
Okay, so as the fluid concentrations change, so will water movement. Because remember, here not only is the water leaving, but because of the increased capillary membrane permeability, everything goes out. See, proteins, water, plasma, they are all leaving the vascular space and entering the interstitial space. Okay, so when this thing stops, then this will also stop leaking protein. And then eventually the concentration will be restored, and then by osmosis again the vascular the osmotic pressure or osmotic concentration of the blood returns to normal now, and
I
so
see,
now
because the
water.
viscosity exerts the pressure.
I'm sorry.
So the vascular space exerts the osmotic pressure to return the water into it.
No, as the again the reason why the interstitial space became more concentrated compared to the vascular compartment was because the proteins were leaking out into that space, so thereby increasing the osmotic pressure at the interstitial compartment. But once that stops though, because your body eventually replenishes the protein, that's constant. No,
Okay.
we are
See, I didn't realize that
constantly.
that happened. Okay.
Oh yeah, naturally, we lose protein, we replace it. So eventually, as long as we stop leaking that protein into the interstitial space, the body can catch up, replacing the concentration of the plasma. And then at that point, just passively by osmosis, water will return back to the vascular compartment.
Thank you so much for explaining that.
Alrighty. So you're okay with the fluid and electrolyte changes? Again, initially we have hyperkalemia and hyponatremia. However, as the patient gets worse, both will now be low. Now, I keep emphasizing this because a graduate did get this question on the NCLEX. She came back, although again, you're not supposed to be talking about the NCLEX, but we appreciate it when you do. 'Cause, again, as the patient gets worse, both will now be low. Now, I keep emphasizing this because a graduate did get this question on the NCLEX. She came back, although again, you're not supposed to be talking about the NCLEX, but we appreciate it when you do. I mean, I'm not telling you to commit a crime, okay? Because that can be perjury because you signed, you swore that you're not going to talk about the NCLEX.
Okay.
But I won't tell your name, okay? But in case something should happen to me, I put a few things in a piece of paper, you know. All right, for kidney and kidney and GI, these are part of the compensation again, okay, because of the decreased renal perfusion. So of course, oliguria will occur. Okay, they'll for a while they will stop producing urine. There will also be low peristalsis, so that's why these patients will have hypoactive bowel sounds. They'll have nausea, vomiting, and so they need a nasogastric tube. I don't know if it was shown on the picture earlier, but probably not. A burn patient will have several tubes inside them. One will be a nasogastric tube, another is a feeding tube, and of course you have the ET tube and then a Foley. Okay, so a lot of fluid, I mean tubes, um, hanging out from this patient. Metabolic, you are in a hypermetabolic state, so meaning your metabolic needs can reach up to 5,000 kilocalories a day because your body is actively trying to repair tissue damage. So that's why your metabolic rate increases. So does your metabolic requirements. Oh, here's a nice picture. So let's count the tubes here. So we have a Yanker, which we saw earlier in lab. So here's a ET tube. And this one here is yellow. So that's a feeding tube. And on the other nostril should be a nasogastric tube. It's probably this one right here because this one is taped. So this is your nasogastric tube. And not shown here, of course, is a Foley. And you see how we have this nice thick blanket around the patient because they have thermoregulation problems. Yeah, so this is a nice heating equipment, okay, for the patient. Look at how many pumps this patient has. Right, very busy. All this equipment for one patient. It'll also be the same in your COVID-19 patients today. They'll have the same setup. Okay, you have an intubate and you have a ventilator, feeding tubes, suction, multiple IV pumps. So this is the SIRS I mentioned earlier. These patients, although during the first 24 to 48 hours, your priority is airway and shock, meaning you want to maintain perfusion and make sure they have good gas exchange. Doesn't mean they're free from infection. So at the same time, also, you have massive burn wounds here, all at risk for infection. However, again, our priority is to make sure the patient's airway and gas exchange is okay and that perfusion is maintained. So as soon as those are taken care of, now you start taking care of the wounds. So you start wound care. And please don't forget pain management at the same time. Even though there's something we learned in the past wherein um, the deeper you wound, the less pain you have, right? You probably heard that somewhere because the nerve endings were burnt. So therefore, no more nerves, no sensation, no pain. That's not entirely true because even though yes, the nerve endings were destroyed, remember the burn injury is not uniform. Okay, so you have varying degrees or varying depths of burn here. So let's say you got um, burned from an explosion, an IED. Okay, you're in the military. Will all your burn injuries be the same?
No.
No, you'll have areas that have um, full thickness, some areas will be deep partial thickness, and you have superficials. So you, besides, even if it's a deep full thickness burn, it's not entirely 100% pain-free. The patient still reports some type of dull pressure type pain. It's not sharp acute pain, but some pressure type of pain. Sepsis we already did, and SIRS was the one of the stages under severe sepsis, so we've done that already. And we'll come back after the break. Please return at 10:55 and we'll continue with how to manage the fluids and the intubation.
Okay, thank you.
Alrighty.